So, I'm just going to start. Good morning, everyone. Thank you for coming to my talk today. Today, I will talk about neuroendocrine prostate cancer, which is kind of an emerging threat in the field of prostate cancer. And I've been working on neuroendocrine prostate cancer in my basic research for 2 years. So, in the first part of my talk, I will talk about recent findings on neuroendocrine prostate cancer, especially staying on the clinical side. And in the latter half of my talk, I will talk a little bit of my basic research, making it as easily understandable as possible. So, first, review of recent findings on neuroendocrine prostate cancer. I didn't just put this picture as a courtesy for Dr. Black. This is Bayern Munich winning the Champions League. The thing is that, okay, first of all, this is about more, I'll stick to the clinical side, which is probably the most exciting part for many of you. And also, even though NEP's neuroendocrine prostate cancer has been known to be there for many, many years, most of the important findings just came very recently, since around 2011 to now. So that's the time when Germans have been the champions in the soccer. So that's, yeah.
Bayern Munich's won many times before.
Yeah, I know. Okay, so all the prostate cancer in general are first treated with AR axis inhibition. However, they develop resistance to AR targeting therapies, either by, this is a little bit smaller than I expected, but either by like AR amplifications, AR mutations, and intracellular testosterone production, AR splicing, and like other pathway activation, like P10 pathway. And also with enzalutamide, now we know that sometimes glucocorticoid receptors, glucocorticoid takes over the role of androgens. Either way, cells try to stick to the AR pathway as much as possible. Even with the enzalutamide, more potent inhibition using enzalutamide, we now know that they tend to become resistant by further amplifying AR or with another mutations. We know that. So mainly now the drug companies are still going after AR axis, trying to find more potent therapies, or like finding novel ways, like N-terminus targeting the N-terminus of AR, so that they can target all the variants of AR pathway. However, in the future, what will be left in the end after multiple cycles of very potent AR pathway inhibition? We still don't know, but there are some cases, we know that there are some cases that eventually become just independent, totally independent of AR. This is one example, a heavily treated prostate cancer, in the end finally treated with docetaxel and PSA coming down very nicely. However, if we take the look at the CT scans here and here, both with very low PSA levels, we see that there's a huge multiple liver metastasis developed between these parts. So here, tumors have lost AR completely and do not produce PSA anymore. This is one typical case of neuroendocrine prostate cancer. Here's another example. A patient treated again with potent AR inhibition. And with abiraterone, PSA declines from 375 to 8, which is a very, very good response. But patient develops respiratory symptoms, and imaging shows multiple lung and liver metastasis. And when we biopsy these, then we are not seeing typical adenocarcinoma, but it all turned into small cell carcinoma. And I will talk to you about later, but now aurora kinase and MYC ion amplifications are known to be one of the genetic signatures of small cell carcinoma, and it shows that it's all totally neuroendocrine prostate cancer. So we know that these cases do exist where PSA is no longer a surrogate marker and the tumor is completely independent of AR axis. Going back one step, so what is neuroendocrine prostate cancer? So the specialists, especially the oncology people, now are afraid that with development of more potent AR inhibitions, there is an increasing chance of patients ending up with neuroendocrine prostate cancer after multiple cycles of therapy. So Prostate Cancer Foundation, which is a very big funding body for prostate cancer research, has just last year assembled a working committee on this neuroendocrine prostate cancer. And there, many specialists gathered, and they came up with two key papers. I don't know what. So this fact that they came up with two papers rather than one shows that still there's not really good consent among the pathologists and the people in the clinical field. But let's first look at the pathology side. So one of the controversies over NEPC is it really associated with poor outcome? There are papers that suggest the otherwise. And the reason for that is that many previous papers just classify whatever tumor that stains for neuroendocrine markers is neuroendocrine prostate cancer. And there was no further classification between them. So what this meeting first pathology sites did is to classify them into more subcategories so that they would more clearly reflect the clinical outcome. I won't go over all of these, but just being brief, this is adenocarcinoma with Paneth cell neuroendocrine differentiation is when the cells with large eosinophilic cells are with any trans-differentiation is present, and this is usually associated with better prognosis. And this carcinoid tumor is not really so malignant. And so and as you know, small cell carcinoma is the worst one. And this LC-NEC is large cell neuroendocrine cancer, which is much rarer than small cell carcinoma, but clinically behave very similar. And one of the key points here is distinguishing between this top one, usual prostate adenocarcinoma with NE differentiation, and this last one, mixed NE carcinoma, acinar adenocarcinoma. So these are the typical images of those two presentations. Previously, when people classified neuroendocrine prostate cancer, they just intermixed these two entities. This is a typical adenocarcinoma that focally stains for neuroendocrine markers, but most of these also stain for AR as well. And the recommendation from this meeting is that for these cases with typical adenocarcinoma that partially stains for neuronal markers, they are not, their clinical implication is not very clear, and they do act similarly to regular adenocarcinoma. So, yeah, the NE cells in these cases are usually quiescent, and the case is best treated with AR inhibition. And also, in general, routine use of IHC to detect any differentiation in morphologically typical adenocarcinoma is not recommended because it does not add anything to the clinical decision making. On the other hand,
so when the classification is purely based on histopathologic immunohistochemistry classification system,
yeah, for
prognostication. So I'm just wondering, do you know of any molecular data that shows us that they're actually truly neuroendocrine? Or are they just producing chromogranin?
I will talk. Yeah, I will go a bit deeper into that later. Yeah. And the other one. This is the typical small cell or large cell carcinoma with adenocarcinoma. So there are sites of true small cell morphology, small cell carcinoma, intermixed with these areas of adenocarcinoma. And these small cell, when patients have these small cell components, it is known that these are very high grade and very aggressive tumors. And the case may benefit from addition of chemotherapy, mostly platinum-based chemotherapy to AR inhibition. So moving on to the clinical side of recommendation. This is somewhat confusing because actually very strange thing is that their pathological recommendation and clinical recommendation is not really using the exact same criteria. So in the pathological classification, they don't have this anaplastic or these so-called CRPC with small cell carcinoma-like clinical presentation categories. At the end of the paper, they mention in one paragraph that from the pathology side, they classify it as CRPC with small cell carcinoma-like clinical presentation as entity, but they don't really include this in their original classification. But the clinical paper is more focused on this clinically relevant, what we know as true neuroendocrine small cell carcinoma. And here they define several characteristics of this anaplastic, truly aggressive small cell type carcinoma. And some of the characteristics are histologic evidence of small cell prostate carcinoma, either pure or mixed, and that most often present with visceral metastasis. And also, in many cases, they also present with lytic, not osteoblastic, lytic bone metastasis. And often, in the primary case, they form a big, very huge mass in the pelvis. And low PSA, they typically present with low PSA with symptoms that are not in line with the PSA level. And also, of course, presence of neuroendocrine markers. and also short interval of androgen, short interval to androgen-independent progression. So these are what the clinical oncologists define as clinically relevant neuroendocrine prostate cancer. And what we should know, overall what we should know is about the clinical characteristics of neuroendocrine prostate cancer is that de novo small cell carcinoma is very rare. However, incidence of treatment-associated neuroendocrine prostate cancer is now thought to be up to 20% in autopsy series. Personally, I still feel that this may be a bit too high, but still, I can expect that the overall incidence to rise to maybe this level in a few years because we now have those very potent AR inhibition, pathway inhibition drugs. And also, it is now underestimated in the clinics due to mostly we don't really do biopsies in end-stage CRPC patients, but they say that it's probably underestimated. And as for diagnosis, diagnosis can be made by either morphology alone or with concomitant IHC staining of neuroendocrine markers. So in their recommendation, they don't necessarily require IHC staining of chromogranin or synaptophysin because they're not completely sensitive nor they're not completely specific. So if you have small cell morphology, distinct small cell morphology, that's enough to lead to diagnosis. And also, this is one important finding, a very important recent finding. Tempress ERG translocation is seen in 50% of the cases of neuroendocrine prostate cancer, which is actually the same as adenocarcinoma, and which kind of shows that, and also this breakpoint, when they look at the breakpoint of the neuroendocrine prostate cancer, they actually match the site of the primary tumor. So this is kind of an evidence that these tumors actually trans-differentiate from adenocarcinoma to neuroendocrine prostate cancer. And also, clinical utility is that when we see patients with low PSA and large volume, like liver metastasis, we always wonder if that's really from the prostate, right? But the thing is, if we do go on to do biopsy and see this tempress ERG translocation in, even if it's from our liver metastasis site, if there's this tempress ERG translocation, we can be sure that the origin of the tumor is actually the prostate. So what about the treatment? We all know that they are better treated with neuroendocrine prostate cancers, are generally better treated with chemotherapy. And in 2013, there was actually a phase 2 trial giving chemotherapy to those anaplastic type prostate cancer. And it shows that overall, these tumors show high response rate of very short duration to platinum-containing chemotherapies. So 65% were progression-free after 4 cycles, but still overall median survival was only 16 months. And also another recommendation from this paper as well as other review paper is, although NEPC component is non-responsive to AR inhibition, hormone therapy should be continued given the high frequency of mixed NEPC and adenocarcinoma within the tumors. So even when the tumor, like with liver biopsies, the patient shows small cell carcinoma, if you know that the primary was prostate cancer, it is recommended to keep the patient on hormone therapy at this point. And what about other treatments? Essentially, there's no other treatment, even though I will talk about one phase 2 trial of one targeted therapy against neuroendocrine prostate cancer, which is now ongoing. And also, this is another review paper just published this year in Journal of Clinical Oncology, doing a meta-analysis of about 100 neuroendocrine prostate cancer patients. What they found was that median time to neuroendocrine prostate cancer to becoming neuroendocrine was 20 months, and median survival after NEPC diagnosis to death was only 7 months. And in this paper, they also stated that even though chemotherapy gives only very little benefit in terms of effective time, overall, rather than moving just palliative therapies, chemotherapy improved. Giving chemotherapy was associated with better survival. So, is there any hope? Is there anything going on in the field? One recent finding, very important recent finding, is findings about genomic aberrations in neuroendocrine prostate cancer. And this is one very important finding that has come last year. It shows that in general, so advanced prostate cancer, they have often, in many cases, they have p53 pathway loss and p10 pathway loss. However, this RB loss is very rare in adenocarcinoma. RB is one of the major tumor suppressors, but RB loss is very rare in adenocarcinoma. On the other hand, in neuroendocrine prostate cancer, it is lost in up to 90% of the cases. And this is also known in small cell carcinoma of the lung as well. So overall, in this small cell type tumors, RB protein loss seems to be playing a very big role. Also, p53 aberrations is also another important genomic aberrations in neuroendocrine prostate cancer. Indeed, there is a tramp mouse model called tramp mouse in prostate cancer, where they go on to develop prostate cancer. And in the end, these tramp mouse models develop neuroendocrine prostate cancer. And actually, this mouse model is essentially RB and p53 lost mouse model. So these are all in line. So RB loss and p53 loss are probably very important in neuroendocrine prostate cancer. And this is one of the most important discoveries in recent years. One of the groups in New York did next generation RNA sequencing of neuroendocrine prostate cancer as well as adenocarcinoma, and also validated their findings with in total of about 44 neuroendocrine prostate cancer. This is probably the largest series that's there in the world. And they found that Aurora kinase, which is a very important checkpoint protein, and MYC-N, one of the oncogenes especially associated with neuronal crest, are amplified in about half of the cases. And now, and also they show that these molecules cooperated to induce NEPC phenotype. So now they are testing one of the Aurora kinase inhibitors in a phase 2 trial in neuroendocrine prostate cancer cases. So this is now the biggest advancement in neuroendocrine prostate cancer. We don't know how it will come out, but there's something going on in the field. Okay, so why is neuroendocrine prostate cancer so difficult to study? Study of neuroendocrine prostate cancer so lagged behind. If people in here who know about basic research stuff know that for proper study of a disease, we need a proper model. And one of the things that has been lacking in the study of neuroendocrine prostate cancer is this model. Now in the Vancouver Prostate Center, we now have really what we call a supermodel, which is the first field model which actually very clearly mimics the human progression of neuroendocrine prostate cancer. So I will just introduce this model to you. And before going on to that part, going back, where does these neuroendocrine prostate cancers come from? We know that there are NE cells, neuroendocrine cells in the normal prostate gland. Neuroendocrine prostate glands, generally there are luminal cells and basal cells. And these neuroendocrine cells, normal neuroendocrine cells, are interspersed between them. These are generally characterized by abundant neurosecretory granules, and they secrete a variety of neuronal proteins to affect cell growth in autocrine, paracrine manner. And they are actually terminally differentiated and very quiescent type, and they don't express AR or PSA. Maybe 10 years ago, maybe 5 years ago, there were still people who believed that neuroendocrine prostate cancers arise from these NE cells. However, as I've talked to you, recent findings of this temporous Urk translocation in these neuroendocrine prostate cancers kind of denies that these normal cells, NE cells, as cells of origin for neuroendocrine prostate cancer. And also, we know for maybe 20 years or so that actually when we treat androgen-dependent link cap cells are androgen-dependent, typical adenocarcinoma type cells. When we treat these link cap cells in some conditions, they turn to actually express these NE markers and become neuroendocrine-like. And actually, Dr. Ralph Butchin, now working in the Vancouver Prostate Center, was actually the first to find that if we deprive link cap cells of hormones, culture a long time, they start to become neuroendocrine-like. And also, Dr. Michael Cox, also in Vancouver Prostate Center right now, has shown that if we stimulated link cap cells with cyclic AMP, they also become neuroendocrine-like. And also, there are various stimuli that induces neuroendocrine differentiation, like IL-6, HGF, hypoxia, etc., etc. So it looks like becoming neuroendocrine-like is one of the ways that cells come to cope with external stress. However, what they couldn't show is, even though some reports show that these cells stimulate growth of surrounding cells in a paracrine manner, the cells themselves are generally quiescent and does not show any signs of aggressive phenotype typically seen in CRPC. So even though they express neuroendocrine markers, they're not really like clinical neuroendocrine prostate cancer. So, which state does the LINCAP model represent? Is it this state, where it's AR positive and the marker positive state where the cells are quiescent? Or is it this state? Most likely, it's this state where the cells are somewhat stressed and begin to express neuronal markers, but they're basically quiescent. So we don't really have any model for this part, which is really the clinical question we have to answer. And now some people are, including us, people at the Vancouver Prostate Center, are proposing these two conceptual stages of NEPC transdifferentiation. With stress, with androgen deprivation or some kind of stress, tumors become somewhat NE-like, neuroendocrine-like. They start to explain neuronal markers, and they start to look like neuronal. However, these are generally reversible, and it's now called kind of epithelial plasticity state, where the cells are stressed. They try to cope with those stress by becoming neuroendocrine-like, but this is usually reversible. And this state, it seems this is the state which can be actually modeled by the LINCAP model. On the other hand, at this stage, we know that in these these true small cell carcinomas, in addition to expressing these neuronal markers, we now know that there should be RB loss or some key genomic changes, like RB loss or kinase amplification, MECAN amplifications, and so on. And this is the NEPC with genomic aberration, which is non-reversible. They have change at the DNA level, and and there's no existing model for this. And recently, YZ Wang's group at the Vancouver Prostate Center is now grafting human samples, human prostate cancer samples, into subrenal capsule of mouse models and trying to grow those human cells in vivo, in mice. Those are called patient-derived xenograft models. And they really very clearly mimic what's happening in the human sample. So this is a human case, human adenocarcinomas case, and this is the xenograft from those cases, which shows very good gland-like structures, and also staining very similarly to the patient samples. This is an example of neuroendocrine prostate cancer from a patient which was implanted into those mouse renal subcapsule. And here again, these AR loss, PSA loss, and this synaptophysin staining, these are mimic very closely the human samples. And one of the newest xenograft models in line is this 331R model, 331 models. This is from a patient with normal adenocarcinoma with Gleason 8 prostate cancer, which was implanted into mice. And if we castrate this mouse, growth goes down. So it's first originally responsive to to androgen deprivation. And this blue is PSA, and this green is growth. And in the end, this cancer recurs without a rise in PSA. And if we look at serial IHC staining, we can see that at the beginning, it's AR positive, PSA positive, chromogranin negative tumor, so adenocarcinoma. However, over time, in the end, this turns completely neuroendocrine. So morphologically, this is now small cell carcinoma, and it loses PSA as well as AR, and on the other hand, it expresses high chromogranin. So this is really the first in-field model which actually can mimic the development of neuroendocrine prostate cancer. So using this model, we actually on this from here, this is kind of what I've been doing, but we try to see the genomic changes along this time course and see what's happening in the interval. And what we found is that even though it's adeno and neuroendocrine, it's not like it's all the same throughout until it becomes neuroendocrine. There's actually a kind of a gradual trend toward NEPC. This is just the overall, how the overall genomic changes are. And as you can see, these are the neuroendocrine groups, and this is the complete adeno. And it kind of branches, but gradually trends toward neuroendocrine prostate cancer. And if we look more closely into each of the genes, as you can see, AR-regulated genes go down gradually, and neuronal markers are high at the end. And there are cell genes that goes up and then down at the final stage, and there are genes that continuously tries to go up. So and another thing that's very good about this model is in this model, RB pathway is dysregulated at the neuroendocrine stage. So the problem about LINCAP model is that it wasn't associated with genomic changes important for studying the true neuroendocrine prostate cancer. However, in this model, this is our RB loss signature. So as you can see with this 331R is the neuroendocrine. With neuroendocrine, you can see all this red, but with the other panel of, this is a panel of human-derived xenografts, as well as some of the, this is 3311 model, which is the mother of this neuroendocrine cancer. And these are the two time points in between. So there's no RB loss in these models and only in this final neuroendocrine stage. And in addition, the xenograph model also had a mutant p53 as well. So in summary, this model acquires NEPC phenotype with loss of RB signature in the background of aberrant p53 pathway, which is exactly what's happening in the human clinical human specimens. So finally, I will talk about how I use this model to actually find a novel therapeutic target for this. For aura kinase, in this model, it wasn't really changed. Actually, in aura kinase, it's changed in about 50% of the cases. And also, it might be that NMYC amplification and some of the gene signatures otherwise changed might be exclusive. We don't know yet. So, So from here, this is completely my basic research topic, but what I try to do is to try to find a novel therapeutic target for clinically relevant aggressive neuroendocrine prostate cancer. And as a first step, I looked at the clinical samples. Here are the list of the differentially expressed genes between neuroendocrine prostate cancer as well as adenocarcinoma in Vancouver Prostate Center cohort, as well as the cohort from the largest cohort in New York. And we tried to look at the overlap. And these are the so if we go to the right upper quadrant, these are the highly expressed genes in both data sets. And when we look at these genes, we found that these are actually terminally differentiated neuronal genes. And as you know, when cells terminally differentiate into really neuronal phenotype, they should become quiescent. Neurons don't really grow. So mostly these changes are passenger changes and not really associated with aggressive growth or aggressive phenotype of prostate cancer. So next, what we did is overlaid the genes that was upregulated by 12 weeks post-castration in our xenograft series right onto this panel to look at the genes that's changed earlier in the time course, not at the terminal neuroendocrine, but the earlier course, to see whether we can find a gene that might be more suitable for targeting, that might be associated with growth or aggressive phenotype. And we turned our attention to this biggest circle, which represents the fold increase, this gene called PEG10. Actually, on this gene, we also have data that this gene was not regulated by one of the master regulators of neuronal signatures. So we know that this is not really the neuronal type gene. And so there's a chance that it might be associated with the aggressive phenotype. Oh, sorry, there's some overlap here. And we looked at the expression of this gene. Very interestingly, it shows 2 steps of peaking, one right after day 1, right after castration, and again at the final neuroendocrine state. This was also seen with in the patient cohort. This is neoadjuvant androgen-treated, hormone-treated cohort, and these are hormone-naive tumors. These are the neoadjuvant-treated tumors, so it's higher after neoadjuvant, and these two are both neuroendocrine. So it's higher after androgen deprivation, and it's even higher at the final neuroendocrine stage. And we also checked with immunohistochemistry that PEG10 is upregulated in small cell carcinoma. And if we look at prostate cancer in a mixed tumor, it stains very strongly at the small cell foci, but not much in the surrounding adenole. And also when we look at the databases from lung cancer, it's also highly expressed in lung small cell cancer compared to the other types. And also, one of the key features of neuroendocrine prostate cancer is high propensity to metastasize. So we also look at several publicly available data to see if it's associated with metastasis. And in 404 very large series, PEG10 was also highly expressed in metastatic tumors. And this was checked, we confirmed high invasiveness or invasive ability of PEG-10 was checked using matrigel invasion assay by us, where if we treat the cells with TGF-beta, cells usually invade a lot. But if we knock down PEG-10, there's not much response to TGF-beta. So PEG-10 is really associated with the invasion of the cancer cells. So going back, what is PEG-10? It is paternally expressed 10, meaning that it's a maternally imprinted gene that in which only paternal arrow is expressed. Very interestingly, many of the paternally expressed genes are oncogenes, and maternally expressed genes are tumor suppressor genes. So PEG-10 falls in a group of possible oncogene. And also, PEG-10 is a retrotransposon-derived gene, which is kind of a viral gene. Its genome was integrated right before the development of mammalian state, and so it's kind of a viral oncogene. And in fact, very interestingly, PEG-10, this viral mimics of this gene and enables it to, it has this GAG, just like the virus. It has GAG domain, and this is a POL domain. And it has retroviral aspirator protease domain, which enables to self-cleave itself and produce various isoforms here. And I won't go into detail, but these are the expressions of isoforms. Actually, this one, top 4 are PEG-10. The expressions of isoforms are differentially expressed at different stages of this transdifferentiation. And it is also a placental gene essential for placental development, and also expressed mostly in embryonic organs in normal adults, which is good for targeting purposes. It's not or expressed in other major organs. And I will be very quick about this for this part. We found that PEG-10 is actually directly regulated by androgen receptors. So right after castration, it goes up. This is just by androgen axis inhibition, because PEG-10 is directly, generally repressed by AR. And also, it is regulated by E2F1, which is a key active component of the RB pathway. So at the final stage of neuroendocrine differentiation, PEG-10 is up because this E2F1 expressed E2F1 activity is high. And we also could show that when we knock down PEG-10 in 2 cell lines, this is the control. These yellow and red are knocked down. The cell growth is suppressed with inhibition in cell cycle. And also, we could also see that when we in turn overexpress PEG-10, we could promote growth. The difficulty here was we had to identify which of the isoforms could was actually involved with growth. And in the end, we could identify that this isoform, specifically RF1B2, could promote growth as well as cell cycle progression. And one of the interesting findings here was that even though we're using using PC3 and D145, 2 cell line models, we could show that PEG-10, overexpressing PEG-10 could actually promote growth. When we did that, the exact same experiment in lean cap cells, which has wild-type P53 and wild-type RB1, even though knocking down PEG-10 similarly decreased growth, overexpression of PEG10 also decreased growth. Knocking down one gene decreases growth, but overexpression of the same gene also decreases growth. Is it a contradictory result? This is what often happens with research when we are doing research. And it turned out that with both transient overexpression and stable overexpression, it turned out that this overexpression of this isoform actually induces this p53 response here and here. So probably, most likely, PEG10 is so oncogenic that many of the oncogenes are known to induce tumor suppressor genes, probably for the sake of protecting the cell itself. And it turned out and p53 is probably a very important factor in doing so. And the interesting thing is that, so probably in the state of wild-type p53 and wild-type RB, this signal is so strong that it induces p53 response to actually try to suppress growth. Indeed, if we look at these panels, phospho-RB and cyclin D1 are known to be important to reflect cell cycle progression. So there are some evidence of cells trying to progress cell cycle with this p27 going down. This is cell cycle CD cell-dependent kinase, cell cycle-dependent kinase inhibitor. So this goes down, this goes up, this goes up. So there's something going on that's trying to promote cell growth. On the other hand, there are some like p53 or p21 or p14, p16. Those are tumor suppressors trying to slow down the growth. So there's trying kind of counterbalance. So this is the summary. What's happening is in the normal adenocarcinoma, PEG10 expression is very strictly regulated by high AR as well as positive RB and p53 tumor suppressors. On the other hand, in neuroendocrine prostate cancer, PEG10 is highly upregulated, and its activity is also left unchecked with negative RB and p53 status. And this causes proliferation as well as invasion, which are both important for neuroendocrine prostate cancer. So the main message here is we could finally find out, relate these important genomic aberrations to the consequence, the phenotype of this neuroendocrine prostate cancer. So I'll just skip here. This slide. So this is the take-home message. First of all, on tumors with positive neuroendocrine markers staining in otherwise typical adenocarcinoma should be treated as normal adenocarcinoma. And also, given the high frequency of mixed neuroendocrine prostate cancer and adenocarcinoma within the tumors, hormone therapies should be considered either first or in combination with platinum-based chemotherapies. And also, usually CR biopsy for late-stage CRPC is not often performed. We recommend that this to be done, especially if we experience rapid progression with low serum PSA or like discordance in PSA and clinical symptoms. And finally, proper modeling of a disease state combined with sophisticated omics approach helps to identify novel therapeutic targets or biomarkers. And I just had acknowledgement. Yeah, it just ended, but I thank this. I'm very thankful to my mentor, Dr. Colin Collins, and Dr. Grieve, as well as Dr. YZ Wang and Amina, and all the other members of the Prostate Center. Thank you.